So my name is Jen. I'm a dietitian at Nationwide Children's Hospital in Columbus, Ohio. And I, want to thank the organizers for this conference and for inviting me today to talk to this fantastic group about nutrition management in the child or adolescent with pediatric inflammatory bowel disease. And this afternoon, what I want to discuss is the nutrition risks that are associated with pediatric IBD, and then understand how nutrition can support children and adolescents with IBD, and then discuss current nutrition therapies for pediatric IBD, including the efficacy and the uses. And let's start with nutrition risks for pediatric IBD. Approximately 20 to 30% of patients with pediatric IBD will present with malnutrition. And malnutrition is an imbalance between nutrient requirements and intake, and that results in deficits in energy, protein, or micronutrients, which may negatively affect growth, development, and other relevant outcomes. And as you all know, during childhood, there is a lot of growing going on. So it's really something that dietitians and all the providers, I feel, use as criteria when we're assessing how well our patient is doing or if they are in some need. The Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition created some specific criteria to help us diagnose malnutrition. And this grid is a little small. Hopefully you can read it a bit, but I put some references over on the side at the bottom in case you want to look at those. But this gives some of the criteria for diagnosing malnutrition. And in pediatrics, only one criteria is needed in order to diagnose malnutrition. In adults, it's a little bit different, which our next speaker may be discussing a little bit in more detail. But for peds, one criteria. And so some of those criteria are using BMI Z-score as a single data point. And if you have a few data points, you can look at percent weight loss. You can look at changes in BMI Z-score to diagnose malnutrition. And if you are able to get an intake, a history of food intake, you can also use that as criteria. And so your dietitian can really help you in these areas, but you can also take a look at growth charts and do some of this evaluation yourself. Approximately 25% of patients with IBD also present with a deviation from their growth velocity and their height for age percentiles. This is more pronounced in Crohn's disease, and it's more prominent in boys. Bone age and puberty can be delayed in Crohn's as well, and bone mineral density is significantly lower than healthy controls. In addition, we do see micronutrient deficiencies, and I'm going to spend a little bit of time speaking on kind of each one of these more common deficiencies that we can see. So we have listed 5 different nutrients that are most commonly associated with deficiency in pediatric IBD, and you can see in the prevalence column that it's there's wide percentages in the literature. I would say that we most commonly see at Nationwide iron deficiency and iron deficiency anemia and vitamin D insufficiency and deficiency. Those other 3 listed, vitamin B12, folate, and zinc, are not as common in pediatrics. However, it's important to keep them in your mind when patients present with risk factors, and I'll speak about all of those risk factors in the next couple of slides. You can see where absorption happens on this slide as well, and often, sometimes we will see these deficiencies more commonly in patients that have Crohn's disease. However, it's kind of across the board with Crohn's and ulcerative colitis, despite where absorption usually happens. Some of the signs and symptoms I think are important to remember because your patient might be feeling those signs and symptoms, and I think it's important to discuss that with them as you're checking labs. And this can be for children and teenagers a good feedback mechanism that if they have a micronutrient deficiency and they're feeling symptoms in the moment, them choosing to treat that deficiency or being compliant with treating that deficiency and then feeling better, it might be positive reinforcement. I know it's a hard thing to ask kids to take supplements, and when we're asking them to take a few different ones, I try and I try and tell them that hopefully they'll be feeling better if we get these micronutrients treated. And you can see that iron, B12, and folate all can impact cognition. And so our kids are also learning a lot. And so it's really important that we think about these things and ask if they're having any symptoms of these deficiencies along with checking the labs. Oh, and one more thing to note with that last slide, that any patients that do have liver involvement as part of their IBD, it may also be prudent to check some of those other fat-soluble vitamins like vitamin A or vitamin E too, because they may be deficient in those as well. And then I'm going to take the next few slides to talk about each of those labs to check and maybe how often and how we might want to treat those. So first off is iron deficiency and iron deficiency anemia. There are many ways to evaluate for iron deficiency. So if you have a way in your center, then by all means use that way. What we usually do is we're looking at CRP and hemoglobin, ferritin, and transferrin saturation. So ferritin is an acute phase reactant. And so when inflammation is present, we have different cutoffs than when there's no inflammation present. So that's why we're looking at CRP and hemoglobin. If you have other labs that are indicating inflammation, then you can also use those other labs when it comes to an evaluation. I think it's important to check at diagnosis. 80 to 90% of patients who present with IBD, pediatric IBD, will have iron deficiency or iron deficiency anemia. So it's important to check at diagnosis. And I think yearly it is important to check, as well as anytime that hemoglobin is low. And I don't have listed on this slide, but I also think it's just as important that we also check every 2 to 3 months if you're treating someone for a low value. So we want to see that our interventions are showing an improvement, and if they're not, are our patients being compliant, or do we need to change the treatment? And then when it's resolved, can we come off of something? Most of our patients won't need iron for the rest of their life, so that's an important piece of this as well. For iron treatment, there's a few ways you can treat. You can treat orally or by IV, and they both have benefits and pitfalls. So oral iron is usually a daily dose. It's pretty easy, inexpensive. However, it could cause GI upset, and there are different forms that are gentler than others. Usually, if we use a gentler form, we dose it a few times a day versus one time a day. So sometimes that's kind of the trade-off. It's easy to remember. It's easy to do as long as you remember, right? So that would be another thing to think about. And then iron through IV, depending on the iron source, sometimes it only requires 1 or 2 infusions to treat the iron deficiency, which is fantastic. Sometimes you're limited by insurance for what kind of iron source you can use, so that might not always apply. They're relatively short infusions. For the most part, I think our infusions are about 15 minutes. And if your patient is already receiving infusions, it might not add too much extra time and they're already in the infusion center. They are expensive though. They're usually well tolerated and most people feel pretty good after receiving one. So there's, just 2 of those things to weigh when you're trying to think about how to treat iron deficiency or iron deficiency anemia. Moving over to vitamin D, we check a 25 hydroxy vitamin D level. I think it's important that you're checking this at least twice a year for maintenance. Usually, here in the Midwest, we would say it's ideal to check when the sun isn't kind of playing as much of a factor. So maybe in the spring and the fall time, for you, wherever you live, it may not be as much of, it may not matter as much. And then every 2 to 3 months, if it's a low value, and you're going to see that with probably every one of these slides, every 2 to 3 months if you're treating and if it's low, so that you can see if your intervention is working. There's lots of ways to treat vitamin D, and I have to say, I don't know which way is best. I've tried all of these different ways. I think any of them can help your patient, and it's just what works best for them. So you can treat with a one-time very high dose. Sometimes this is called Stoss treatment. Stoss is a German word which means to push. So it's just like a one-time very high. You can see the doses Anywhere in the literature, I've seen between 300,000 and 600,000. It's usually well tolerated. Sometimes we'll do this when patients are hospitalized and they're kind of a captive audience. We can just give them a one-time dose. You can treat your patients weekly, so they can get like a once-a-week treatment for a couple of months and then recheck a level. You can also just treat your patients daily, 2,000 units a day or up to 4,000 units a day, depending on how their levels respond. And then I do think most of our patients will actually need to be on vitamin D all of the time, unlike iron. So that might be something that you might want to discuss with them. And then the next several nutrients aren't as common, but we do think about them when risk factors are present. And so for vitamin B12, a patient would be more at risk for being vitamin B12 deficient if they had significant ileal disease, and we would consider that more than 20 centimeters of involvement. If they've had an ileal resection or if they're vegan. And I would say by far our most common reason for someone to be vitamin B12 deficient at our center is going to be a vegan diet and they're not supplementing. So I would say it can take several years for a B12 deficiency to occur when you've had a resection, but it's still important to check every year. And what we would hope is that ileal disease would be treated, and even if they presented with that much inflammation, hopefully they wouldn't have that much inflammation once medications were started. There are different ways that you can treat B12 as well. So you can treat with injections. You can also treat sublingually or using a nasal mist. Those two forms may not be covered by insurance, but that might be a preference to your patient or your family. And you can also treat orally. So we would usually recommend this mostly for someone who's a vegan. It's not that they don't have the ability to absorb B12. It's that they're just not getting enough of that in because it's found in animal products. So that's what makes them at risk for B12 deficiency. I have seen a little bit of literature looking at treating B12 deficiency in those that have had resections with oral B12, but that's very, there's not a lot of literature showing that. I think the injections are probably what would be preferred in that scenario. Folate deficiency could occur if someone is on sulfasalazine or methotrexate and they're not taking folic acid supplementation because it interferes with folic acid absorption. And also another risk factor would be severe small bowel disease. I have to say, though, in all of my years at Nationwide, we have never seen a folic acid deficiency when we've, checked serum levels. I do think, or folate RBC, I think it's a hard level to check for one, but I don't think that, at least in our developed world, it's very prevalent because folate is highly fortified in a lot of our foods. But if your patient is on one of these two medications, then it's recommended just to do daily dosing of 1 milligram a day. And if you're found to be deficient, that is actually the treatment, is 1 milligram daily. There is a little bit of literature for those taking sulfasalazine or methotrexate that you might be able to just treat weekly, especially if they're on kind of a weekly dose of these medications. But that's just a very small amount of literature on that. So I would probably default to the daily dose, and it's a vitamin that we would just excrete through our urine if we got too much of. So no concern for getting too much of that. The screening for B12 and folate, they kind of mesh together, so I put them on one slide. So for B12, we'd want to check a serum B12 level. For folate, we would want to check a folate RBC. Sometimes other labs are more sensitive. So methylmalonic acid and homocysteine are more sensitive than the B12 and folate. It can detect those deficiencies sooner. However, they're often send out labs, and they are for our institution. And so they might be something you might consider with care. If somebody has one of those high risk factors, maybe you want to check those levels. And so I think that it's important to check annually if they have risk factors present. If they have a high MCV, that could also indicate that they have a folate or B12 deficiency. And then, of course, every 2 to 3 months when you're treating any kind of a low value. And here's kind of a little table that just shows you kind of the interplay between that methylmalonic acid and homocysteine level and B12 and folate deficiency. And then lastly, zinc. So I think that you can see zinc deficiency. It is hard to check that in the serum level, and I'll talk about that in a slide or two, but some of the risk factors would be severe small bowel disease or resection, similar to the B12. Excessive diarrhea is probably the largest risk factor, or if someone has a fistula and having a lot of output from that fistula. Not so much a low alkaline phosphatase, but sometimes there have been some indications that that can indicate a low zinc level. Serums, there's a few different ways to check zinc. You can check it in the urine. As serum zinc is probably easiest. However, it's an acute phase reactant, just like ferritin. So levels might be impacted when inflammation is present. We think maybe just checking these levels if the risk factors are there. And treatment would be 1 milligram per kilogram up to 50 milligrams daily for your patient, for your small patient. And you could treat empirically as well. So if you have a suspicion that someone has a zinc deficiency, if they're having any of, those signs and symptoms that that was in that other slide in the very beginning, which would be alopecia or poor wound healing or poor growth, then you could treat empirically for a few months. I wouldn't do it long term, but you could treat empirically for a few months. And then this last slide kind of pulls it all in to what are those contributing factors to nutrition considerations. And so what we have is all of the things that contribute for pediatric IBD to malnutrition: underweight, altered body composition, growth failure, bone health and puberty delay, micronutrient deficiencies, and anemia. So the suboptimal intake can be a result of decreased appetite and food aversions, increased nutrient utilization and altered metabolism as a result of the activation of the immune system and tissue repair, and then energy and nutrient loss from malabsorption, gut losses, diarrhea, those types of things. So it's multifactorial. It's nutrition related and just disease related that can contribute to nutrition issues for your patients. And now let's switch to thinking about how nutrition can support your child or adolescent with inflammatory bowel disease. When a dietitian performs a nutrition assessment, these are some of the buckets that they're going to be looking at. And we've talked about these first two buckets, the weight and growth and the biochemical. They're also going to ask your family about what vitamins, minerals, herbs they're taking, supplements. And hopefully they'll be able to get a detailed list, and hopefully they'll ask and get a detailed list, but you can do this too, because there are many herbs and supplements that do interact with our medications that we treat IBD. So it's important to ask your families. We ask about activity to know how much extra, energy they're burning, and just to get an idea of how they're doing overall. If they're usually a very active individual and play 4 sports and they're not able to do any sport, that really can give an indication of how well they're feeling medically, and then their nutrition can be impacted because of that. We want to ask about knowledge and beliefs about nutrition. Everybody has knowledge, like everybody has their own set of beliefs about nutrition, and it's important that you're on the same page when you go into discussing any kind of intervention you might want to do. So I always ask, how much of a priority is nutrition in your life? What would you say some of your beliefs about nutrition are? Ask about their food and food culture and cooking skills and all of those types of things. And if they do dinners out or dinners at home. So it's just a lot about kind of the aspect of eating, I think, is important before you get into making suggestions. You have a little bit of knowledge about what they do already. I always ask about usual intake, and then what is our intake limitations currently? Considerations that go along with those different buckets We really, overall for kids, we want to encourage healthy eating. That is the most important thing. And so we want to do that, we want to help them manage any perceived food intolerance, and it could be temporary or it could be long term. So we really want to talk about that at diagnosis. If they're having a hard time tolerating some foods, that might get better over time. And we really want to make sure that we're identifying and discussing any maladaptive eating behaviors, because we know that it can happen with IBD. And so if it's prudent, you can screen for different types of eating disorders like avoidant restrictive food intake disorder or anorexia or bulimia. It should always be on your mindset. And we want to assess if there's any food insecurity. You can do this rather quickly with the hunger vital sign, which is a 2 question screen for household risk of foods insecurity. Our EMR has it built in and it's asked of our patients, but you want to make sure that your patient is asked how often are they being asked? Are they being asked all the time, or is it just a one-time thing? Because things can change quite frequently. So if it's embedded into your system, just make sure you understand how often your system does ask the questions, because things can change from visit to visit. Other considerations, if your patient is on any kind of immune suppression, we want to make sure that they understand good food safety. So some of the things that we would recommend, and these are things we recommend for everybody, but it is more important when they're on any kind of immune suppression: avoiding unpasteurized dairy and juices, making sure they're cooking meats to safe temperatures, washing fruits and vegetables. So those are just kind of some general guidelines, but I always like to talk about it. So I think it's important that they just understand that there can be an impact from their medications. I had mentioned drug nutrient interactions. These are not just the three nutrient herbs that interact with some of the medications, but these are common. So I have a lot of patients that take elderberry in the winter or all the time to just kind of help fight the colds that are going around. Well, it's supposed to enhance your immune system, and that's not what we want. We want your immune system suppressed, so it could interact with any immune suppression. Same with echinacea and ginseng. So if there's anyone that's taking something to boost their immune system other than vitamin C, you want to advise them that could interact with their medication. And there are other types of herbs that do interact. What we have access to is the Natural Medicines Comprehensive Database. And so you may at your institution have access to that as well. It's great. You can just type in what you're looking for and it will give you a lot of information about that specific herb, what there's efficacy for its use, potential safe doses, interactions, things like that. So that could be a good resource for you. And then I already mentioned kind of knowledge and beliefs, but we want to think about this in cultural considerations as well. What kind of foods does our family eat? What kind of cultural influences do they have when it comes to food and nutrition? And we want to try and maintain that as much as possible and most likely encourage that. So when we take in all of those answers to the questions and all of those different buckets or all those different data points, then we want to potentially provide some information back. And so I think in general, I like what this slide represents, and then we'll talk a little bit more about it more in detail. But in 2020, a guidance report was published from the International Organization for the Study of Inflammatory Bowel Disease. So mouthful. And it provided expert opinion regarding specific dietary components, food groups, and food additives that may be prudent to increase or decrease in the diet of patients with IBD to control and prevent relapse. And so some of these, you can see at the top, it's separated between Crohn's and ulcerative colitis, but fruits and vegetables, the top, very easy to understand, and omega-3s from fish. Very easy to understand, but the bottom part is not very easy to understand for the most part. So it calls out to avoid saturated fat and trans fat. Doesn't say where they're found, but they're found in animal fats, palm and coconut oil. Emulsifiers and carrageenans, those are found in dairy products, dairy alternatives, processed meats. It can be in condiments. Maltodextrins, that's a thickener that's commonly used in foods and confections and artificial sweeteners. titanium dioxide, which is used as a food additive to coat, color, or preserve food. And so these are the types of recommendations that was provided in the study. And they were limited because they were consensus opinion, use small studies. Sometimes the recommendations were based on results of experiments with animals and just practicality. I don't know if anybody would understand what to avoid. It would maybe sound like everything you should avoid other than fruits and vegetables and fish from reading this. So it's really important, because some of these guidelines are out there, that your families have access to a dietitian or have some good resources to be able to interpret, what actually am I supposed to be eating? I think if you take the idea of this slide and you had to put it into a style of eating, I think it would follow the Mediterranean diet, which is lots of fruits and vegetables, plant-based proteins, lean meats from fish and omega-3s, not a lot of red meat, low-fat dairy, so kind of decreasing that animal fat, and then not a lot of processed food. And I will say that, thinking about setting up this slide, we do have a little corner that has optional wine on there. We have a wine and non-wine photo in our education materials because we see young adults. And so we give that to the young adults, and we have the non-wine one for the peds. So I think that in general, this sums up, I think, what this other consensus report was trying to give some general guidance on. Now, if your family is following kind of a standard American diet, I think these are great principles for them to try and adopt. I think if their family's not from America, and if you have a patient that or family are following more of their cultural cuisine, I would just ask more questions, because they may be following the principles of the Mediterranean diet already. So there are other cuisines that are high in fruits and vegetables and plant proteins and don't eat a lot of processed foods. And so I never walk into seeing a family and say, this is what I would recommend. I ask how they typically eat. And if it's usually like a standard American diet, then this is the guidance that I give if they're willing to let me give it to them. If they have another type of culture, we just talk about their cultural eating and see if there's other ways that we can adapt kind of the ideas of the Mediterranean diet into what they currently eat. Hopefully that makes sense, what I was trying to explain. If your patient has IBD and it's in remission, but they're still having a lot of GI symptoms, and they also have and they also have irritable bowel syndrome, they might get benefit from following a low FODMAP diet, at least temporarily, or until they can identify some foods that might be contributing. So the low FODMAP diet, there's not efficacy to use it for the inflammatory process. But if they are having GI symptoms and their IBD is in remission, it could be something to try, to talk to a dietitian in the family to see if that might be something that could be helpful for them. And then lastly, I'd like to just take a little bit of time to discuss nutrition to treat pediatric IBD. So the other slides were more of supportive measures. So what are things that are going to be positive and help my overall nutrition and keep me having a great relationship with food, and that we don't have any hard, fast rules. No, many of our patients can live their life with no food rules, and we like our pediatric patients to feel that way. But if we want to use diet as treatment for IBD, it can be very successful and efficacious. And in that regard, we might have some food rules, but it's different. It's using it as your medicine. So these next few slides are going to suggest using nutrition in that treatment sense. Exclusive enteral nutrition is using liquid formulas to treat Crohn's disease. And we call it at Nationwide just nutrition therapy. Our patients don't quite understand what enteral means. It's not a pleasing word. We don't find that anyone's ever enjoyed us talking about it that way. So we use a more positive way of speaking about it and just call it nutrition therapy. And so exclusive enteral nutrition or nutrition therapy is using those liquids, those liquid formulas as a as a sole source of nutrition. And we like to refer to them as nutrition shakes versus nutrition formulas. And then partial enteral nutrition is doing a bit of those shakes in addition to regular foods. And it doesn't have as much efficacy, but it is something that some people will do. Exclusive enteral nutrition, it induces remission in Crohn's disease. There's no difference in efficacy between exclusive enteral nutrition or corticosteroids in treatment in children. Height velocity is significantly increased when you use EEN compared to steroids. And I think at this point it's got 60 to 70, 60, 40 to 60 years of experience showing that it's an effective treatment. Some of the pros of exclusive enteral nutrition is it's easy to start because many of our patients can just drink it by mouth. And so they could go to their grocery store and we have some guidance on complete nutrition shakes. We wouldn't want something that doesn't provide complete nutrition. So it couldn't be, more of a retail drink. It would need to be something that's more located in that pharmacy area. But you can use a milk-based or polymeric formula, which usually tastes okay. If you like milk, it tastes okay. And most of our patients will respond in 1 to 2 weeks. So it doesn't take forever to work. It improves malnutrition. It doesn't suppress the immune system. It improves the height velocity, like I mentioned in the slide before. It improves surgical outcomes. So if you have anybody that's coming up for surgery, it can significantly improve their outcomes. And it doesn't have any of the side effects that you see with steroids. So lots of pros, but there's some pitfalls too. It may not be effective for someone with severe disease who has any of those extraintestinal manifestations of disease, or anyone who has stricturing or penetrating disease or fistulas. So it may not be strong enough to work in those most severe cases. You can definitely get tired of the taste if you're drinking nutrition shakes all day long and that's it. And in that case, it's hard to do long term. It does limit participating in the social aspects of eating. And so those are not, just because the list is shorter, doesn't mean that they're not less important or as impactful, even more impactful than the pros. But it is just something to think about on both sides. And, we have patients that can do it successfully. And we have patients that when we think about using it for them, we want to think about it in the short term. And so some of the indications for use would be, these are a little thinking outside the box too. So if you have a patient who is on immune suppression and they have an active infection and they have to hold their medication, you could try to use EEN as a bridge. And so that would be a short-term solution, right? So we have done that for patients. Depending on if your clinic has a pharmacist. We have a pharmacist, so our PA time is not very high, but there was a time when we didn't have a pharmacist and we did have a longer PA time. But if you find that based on certain medications, you can expect prior auths to take a while, you can have your patients do this while they're waiting on their prior auth, and they can get treatment for the week or two or longer that it takes. Or if they're not quite sure what treatment they want to do, if they're deciding on what kind of medication, or they want to talk to, another family member or whatnot, they can do this just buying shakes, drinking shakes until they decide. And then they're getting some form of treatment. You can do it, like I said, for surgery optimization. We can, and we have, and not so much anymore because I'm going to talk about the food-based diets. We use those more often, but you can use it for induction for mild to moderate disease. You just have to have a plan for maintenance if you don't want to continue doing it long-term. But I have had some patients that have done it long-term, and we do kind of a mostly nutrition therapy at that point where they get maybe, a small meal or two, and then they do the rest as shakes. And you can do it as adjunct therapy. So if a patient is on a medication and they have a flare and the family doesn't really want to up the dose of the medication or the interval of the medication or change the medication, they could try and induce remission with exclusive enteral nutrition for a few weeks, and then maybe they might be able to wean off of it and be able to be maintained on their medication that they were previously on. So that's another way. So that sends me into talking about some food-based diets, because drinking a liquid, that's really hard to do. So could we just replicate the same idea with food? And in peds, there's a few that we would recommend. So one is Crohn's disease exclusion diet. It was first published in 2014, and the first few phases do rely on partial enteral nutrition and with a guided diet. So in the past, there have been some studies looking at 50% partial enteral nutrition with what they call a free diet. You can eat whatever. That is not effective at all. But this has shown to be effective. The first phase is 6 weeks, and it's 50% of your intake from a liquid shake. And then you have, they don't call it mandatory foods anymore. They just call it recommended foods. But eggs, chicken, potatoes, bananas, and apples for a source of lean protein, resistant starch, and pectin, which they all think are very, nourishing for the body and gut. And then there's allowed foods. You can have a lot of fruits and vegetables, rice as kind of your main starch. And you do this for the first 6 weeks, and then you can transition to phase 2, which is 6 more weeks after that. You go down to 25% partial enteral nutrition, all of the same foods as phase 1, but you get to add some other starches, which are great: quinoa, oatmeal, homemade bread, lentils, nuts, and some other foods. So it becomes less restrictive over time. And then after 12 weeks, you go into a maintenance phase, which is basically phase 2. You don't have to do the shake anymore unless you want to, in case it would improve your nutrition. But you can have a few what they call kind of free meals every week, where you're eating, maybe foods outside of the CDED diet. If you eat at a restaurant, that would count for both of your meals. But if you're eating home cooked meals and you just want to eat, a burger, then you could eat a few meals a few days a week as kind of just to incorporate some regular foods. And so what is some of the evidence for this? And this is that first study that I shared that was published in 2014. So they took a look at a 12-week trial of patients that were doing CDED that had that partial enteral nutrition. And it was kids and adults, but they had over 30 patients that were children in this study, and the rest were adults, for about 50 patients. And these patients did not have severe disease, and they were just kind of stable on their medications. And what they found is 70% went into remission at 6 weeks, which is fantastic. And then they transitioned to that phase 2, and 84% were still in remission at the 12-week mark when they were able to go from phase 1 to phase 2. So that was really good for that first publication. Made me very excited about this diet for sure. This is another study which looked at kids that were kids and adults. So it was about the same amount in each group that were failing biologics, and they added CDED phase 1. And what they found is that 62% went into remission at 6 weeks. These were kids and adults that were failing biologics. So I think it's really remarkable thinking about that adjunct therapy, like adding on, like I said, you can add on the EEN, but you could also potentially add on the CDED. I'm going to show one last study on CDED, but there are multiple out there. But this one was a prospective study looking at a 12-week trial of CDED that has that partial enteral nutrition built into it versus EEN. So it put them head to head. And so these were all children aged 4 to 18, and they had mild to moderate Crohn's disease. Again, I should have mentioned this is for Crohn's disease, just like the exclusive enteral nutrition. And what we found is that it was better tolerated because you're eating foods, it's not just that taste fatigue, and at virtually the same response, 85% response. So that's really nice studies and outcomes for the CDED. So thinking about, just like we did for EEN, some of the uses: induction of mild to moderate disease, I kind of put that at the top. Adjunctive therapy, I would definitely think of using CDED. And then some of the same things when we think about the EEN, treatment during an active inflammation, potentially, if you're waiting for that prior authorization or you're waiting on a treatment decision. that could be something that you could consider. There's, again, not a lot of evidence for those outside the box ideas, but I mean, you'd be providing a treatment for sure. And then lastly, I'm just going to talk really quickly about the specific carbohydrate diet. It is a nutritionally complete, grain-free diet, low in sugar and lactose. And it was initially described in the 80s, widely described in the 80s from a book that was written by Elaine Gottschall. And so it kind of got a little bit of interest in the IBD world, because in the book, it describes that it can help with a variety of medical conditions: Crohn's disease, ulcerative colitis, diverticulitis, celiac disease, on and on. So as you can imagine, it was kind of met with some skepticism. There were a few places that did some studies, very small. So here's one, 9 patients who did a 12-week trial of SCD, and they went and they had a capsule endoscopy, and they found that 60% went into clinical remission with SCD, 40% had mucosal healing. This is another study looking at children age 7 to 18 with active inflammation, and they were enrolled in this trial where they were their own control. And so they were assigned to do SCD or a modified version of that, which was a little less restrictive. Then they had a period of a baseline diet. The hard part is that there weren't a lot of patients that finished this study, which I think is important to note, because this is a challenging diet, not something that can't be done. I have many patients that do it really well, but you have to find the right patient, I think, for it. But 54 enrolled and 21 completed. So only 40% completion rate. And they found that, some haven't had improvement and others did not. So we didn't get a lot of information outside of this, other than, maybe that modified version was about the same as the more strict traditional version of the diet. I'm not going to spend any time on this study, because our next presenter may be talking about it, but this is a study with using CD/ED in adults. And so there's no children that were involved in this study, but it was, something that I was anxiously awaiting the results of this diet, which showed that the Mediterranean diet and SCD, had very similar efficacy. So because there's not as much robust literature to support the SCD, we would think about it in combination with other treatment and, maybe using that modified version. But I do have some families that want to use it as primary, and I just kind of work alongside of them to make sure it's nutritionally complete and they're responding and they're open to other medical treatments if it's not. There's a lot of diets out there, though. I mean, I just didn't even scratch the surface. And a lot of them haven't had any studies in children, but we do have people asking about all of these different diets. So we try and give them as best information as possible and try and be evidence-based. And if you look at some of these diets, I love this. So this was published in Gastro in 2019, I think. Yeah. And all of the diets were kind of listed at the bottom, and then there's different foods along the side. And green means that it is allowed, and more of that brown color means that it's not allowed. And you can see there's really not a lot of agreement in these diets of what's allowed and what's not allowed. So you can imagine how confused our patients can be, or how much they really want to seek guidance, and sometimes how there's not a black and white answer for it. But in general, for nutrition, we want to make sure that we're trying to identify if patients have any kind of malnutrition by reviewing their current intake and offering suggestions for things they can add to meals and snacks, or maybe nutrition supplements. We want to think about vitamins and minerals, how to prioritize if there's multiple that they need to take and they don't want to take them all. What are our patients' current eating practices, and if there's motivation to make change, and how to go about that change. And then how to optimize their nutrition if they need some supplementation, or if they might need NG feeds, or prioritizing nutrition prior to surgery, if that might be the case. So nutrition is an important part of the management. And I think that we want to maximize growth potential and treat and prevent nutrition deficiencies. And we can also use diet in our toolbox in order to treat IBD as well in the pediatric world. Here are some of my favorite resources, and I'm happy to take any questions if there's some time.